64-year-old man with a bicuspid aortic stenosis, very critical, and you can see the calcification of the cusp and also the calcification of the LVOT, and a safari wire has been put, and they'll be pre-dilating this with the balloon, and then we'll be deploying the new Edward Sapien valve. So this is the Sapien 3 Ultra, which we'll be deploying for this bicuspid severe aortic stenosis. So this is the E sheath with a lock. It is expandable, the regular sheath with hydrophilic coating, but it's got a lock, which is the additional advantage where you can remove the dilator. It's a 23mm valve. This is the Sapien Ultra. So what is the benefit of the Sapien Ultra? You see the skirt, it's a larger skirt than the regular Sapien valve. So this is the pre-dilatation because it's a very critical aortic valve stenosis and it's done on the pacing. This is the Sapien, and now we are doing the loading of the valve. So there's a crossing on the valve. This is the descending aorta. Now we are in the ascending aorta and the arch, and that's the mobilization of the valve. It's a gentle valve which does not allow the scraping of the aortic wall. So that is the Edward Sapien Ultra. That's the positioning of the valve at the level of the aortic annulus. Here the problem was the LVOT calcium, therefore we decided to use a 23 and expand it to 24. This is to prevent rupture of the LVOT, which is a problem when there is severe calcification of the LVOT. So that's to show the position of the valve. That's the deployment of the valve. There's a LVOT calcium, so one has to be careful because you may land up with the LV rupture, and this is the pacing going on. Fair amount of calcium. The valve is expanded very well, and you can see that there is no AR and there's no paravalvular leak.
So you might as well do it first time around, because we get good radial strength. Radial strength is what's going to try and alleviate as much PVR.
So this is the apical 5-chamber view, and here you can see the gradient, and you can see the color Doppler, and there is no leak and there is no pericardial effusion. So this is look at the pressure gradient between the LV and the aorta.